here. I'm here today to talk to you more about our Bold Goal work. I'm in the Office of Population Health, focused on Bold Goal. I've been at Humana about 12 years. I've been doing this work for about 4.5. In the last couple of years, I have been leading the loneliness strategy on our team. With me today, I also have my colleague, Amit. He is our data and IT guru for our team. And for this audience, I wanted him to have the opportunity to be able to talk about the exciting work that we're doing in that space as well. So thank you for having me. I'm going to give a brief overview of the Bold Goal. Hopefully most of you know what our goal is by now. I hope. However, if you're newer, you might not. So I did want to spend a little bit of time on that. Want to talk about what we're doing, specifically spend most of the time on that. And so we'll get started. So to get us started, I want you to meet Mildred. Mildred is an 86-year-old MA member. She lives alone, but she can still drive and get around pretty well. She signed up for a pharmacy PDP plan, so she had to call Humana to get all her payment information set up, as well as her monthly mail order set up. She was really nervous because Mildred's never had a credit card, so she's never had to have one. She wasn't sure how she was going to set up the payment, so she was really anxious and nervous. So she called Humana and got connected with a pharmacy rep. That pharmacy rep, once she started to talk to Mildred, really understood that she was nervous and anxious, could pick up on that. So she started to have a deeper conversation with her. And what she was able to do is screen her for food insecurity. And when she did so, she figured out that Mildred every month was making the choice between paying for her medications or getting food. So when we think about people like Mildred, that pharmacy rep really thought of Mildred as a whole person. She didn't think of her as a transaction. So it's really interesting that in the United States, we spend 4% on healthy behaviors. However, it makes up over half of what really makes people healthy. So we've traditionally thought of solutions, medical services as a way to solve for health, but we really need to start thinking bigger than that and more than that and really think about the whole person. So our Bold Goal, which I hope, does anybody know what our Bold Goal is? No? Nobody wants to volunteer? Go for it.
20% by 2020.
And beyond. It's 2020 and beyond now. Good job, though. So our Bold Goal was launched in 2015, but it's essentially a health and business strategy really dedicated to improving the health outcomes of our communities, 20% by 2020 and beyond. And most of you that have been around for a while have probably heard the 2020. But it's really important to understand that this work takes time, and to see and move the needle on health is going to take us longer than 2020. However, it's very important, so we're really have started to do our messaging as 2020 and beyond. So how are we going to do this? So we can't do this alone, right? It takes everybody in the community to be able to drive this work forward. It takes everyone from local government agencies to providers, to health plans. And so we really have to think about how we do things differently and partner differently with these different agencies and people within our community to be able to really move this work forward. I don't know what's wrong with that slide, sorry. Looks like some of the sizing's off. And so what we've been able to do through our work is really understand that addressing those things outside of the clinical setting, such as the social determinants of health, really do impact health and outcomes and cost, and being able to bridge that gaps between those clinical and social needs. So really back to caring for that whole person. So this is a timeline of our Bold Goal. Not going to go through every single thing on this slide. However, it's important to note that we started this work. It was launched by Bruce in 2015 publicly. Over time, we have 7 Bold Goal communities that are really our legendary communities, or however you want to title them, but we've expanded further. So we're now focused on 12 communities and continue to expand. We really worked to focus in on the social determinants of health, as we used Healthy Days as our measurement of that 20%. And we really learned that how we can move the needle on Healthy Days is by focusing in on those social determinants of health. We began to establish partnerships with national and local organizations, physician practices. In 2018, we launched a 12-month food insecurity randomized control trial. Talk a little bit more about that in a minute. But really, it's that we are moving forward in these communities. We are improving Healthy Days. Our Healthy Days have been improved in our bold goal communities compared to those outside of those communities. As I mentioned already, we measure that 20% using the CDC measurement Healthy Days. If you haven't heard of that already, hopefully you have. It is a 4-question survey that we conduct with our membership every year that includes questions about your physical health, your mental health, as well as your activities of daily living. We use that measurement to track our progress over time, and we publish that every year in our progress report that was actually just put out I guess about a month ago, so if you haven't checked it out, make sure that you do. But we've also been able to use Healthy Days for much more than that. It's been able to help us do proactive outreach with some of our members. So those people that's in our Medicaid population that score 20 plus on Healthy Days in a month, we have a team that proactively outreaches to them to help them navigate their social determinant of health and clinical needs. So I want to talk about this slide first. I thought I'd home switch. So when we talk about Healthy Days and gathering that information and the social determinants of health and diseases, we've really been able to understand that Healthy Days is significant in these social determinants of health. So if you notice for Medicare, our average Medicare paid member, their average on Healthy Days is around 13 and a half days. Those that are experiencing severe loneliness are at least double, often more than double, if they are severely lonely. Same with food insecurity. And then also depression and some of our diseases, you can tell on average, those members are experiencing a very large number of unhealthy days each month that is impacting their health. And if you're not familiar with Healthy Days, one other point to make out is that it's a self-perceived measure of your own health. So what a healthy day is to Sara can be very different than what it is for Amit. So as we think about our members, it's very highly correlated with how they're doing every day and how they feel that their health. So, talking about food insecurity. Oh, I want to go back a slide. Sorry, that was my fault. So when we talk about our team and what we're focused on, so you'll hear us talk a lot about food insecurity, loneliness, and then transportation is also a significant barrier to health. We have put a lot of effort behind these barriers to health because we know they're the top drivers of Healthy Days. Loneliness is the #1 driver for our membership. So we know that each of these things have a significant impact on both health and cost. So food insecurity, for example, thinking back to Mildred, 2 in 3 of Feeding America's clients report making trade-offs between food and medication each month. For loneliness and social isolation, I could talk about this a lot of stats around this, but it is more harmful than smoking 15 cigarettes per day. 15 a day. So it has a significant impact on health. You're more likely to have increased utilization, more likely to develop a chronic condition, as well as your increased mortality. So those that are lonely or isolated have 2 to 5 times higher morbidity than those that do not. So talking a little bit about food and what we're doing. Now I'm going to be cognizant of time, so I want to give you enough time. So for food, this is a timeline of food and how we're scaling our work. Just want to point out, I'm not going to go over again everything that's on the slide. Feel free, I can share these slides with you guys afterwards if you want to dive in deeper. Some of the things that I would like to point out is last year we launched a randomized control trial in which had some mobile food distribution, high-touch care management, health education within that program, and our provider offices. we are partnered with some provider offices. We have wrapped that up at the beginning of the years, and we'll have some of those results that we'll be reporting on. But we often do proof of concept tests, or test and learns. Everyone at Humana calls them something different. But we really start out with those small test and learns. We'll do that first, and then want to move to those randomized control trials or outcomes-based studies to have those proof points and insights to push for policy change. So at the end of the day, we really want our work to be influencing policy so that this work and these benefits, or these social determinants of health, can be addressed through our benefits. Something else I wanted to point out on here is last year we screened over 500,000 people between Humana and our partners for food insecurity and loneliness, and we're able to refer those people to resources. This year our goal is 1 million, and we can't do it alone. So if you have the opportunity to screen and talk about loneliness or food, come talk to us some more. So loneliness, we really were thoughtful about our approach. Loneliness is not one size fits all. The root cause is very different from person to person. So we were really thoughtful on how we identify these members within our population. It's not as easy as a diagnosis code or something that's submitted in the claims data. So we did an outreach to our members, and using the UCLA 3-question loneliness scale, screened our members for loneliness. In doing so, we used all of those responses to work with our analytics teams to develop a loneliness predictive model. That model gives everyone in our Medicare Advantage population a loneliness score. That score then can be used as informational purposes for people that are on the front line talking to our members, as an opportunity to have those conversations and to screen for loneliness, again, and talk to them more. It can also be used for targeted interventions. So if we have something specific that we want to outreach to lonely members for, we can use that. This is a model. Sorry, I'm going to talk about this for a minute because I'm excited about this and I want people to use it. So we are using it in those different fashions. We have the Score Live in CGX, which is a system that a lot of our associates that speak with members use. We also have worked with pharmacy as well and have it in their script event system. But there's lots more opportunity for this to either be as a score that appears in our systems that we're using every day, or if you're working on a project pilot, I know you guys are doing a lot of work, there's opportunity to also take those populations and match it up with that model to understand what loneliness looks like within the population. And it doesn't always make sense, but if it makes sense, can have some messaging or some intervention around that to help engage people more. Let's see what else I want to talk about. Oh, so some of the proof of concepts. So Julie is actually doing some great work with Care Coach, if you haven't heard about it. So that's addressing loneliness as well as a lot of other things, but that's something that we've been testing and like to point out for loneliness. We're also partnering with a startup company out of Florida called Papa. They connect college students with seniors for companionship house help. It has been very successful and very well received by our members. So we will be doing more with them and excited to do more with them. We're really at the point now where we were able to reduce loneliness with those members. We were able to reduce healthy days. People engaged in it. Almost close to 70% of the members that did visits were doing visits 4 months later. So people love it. They're also making a very big difference in our seniors' homes. They're forming relationships and bonds that I think can be really leveraged to push for behavior change. So we'll be doing more with them. Currently are scoping out some larger test cases, so if you want to talk more about that as well, let me know. And then, let's see what else I want to point out. So the Meals on Wheels vendor, that was actually a benefit for 2019. I wanted to point that out. So that was something that Jennifer Spear on our team and Emily McGrath led, but they partnered with Meals on Wheels. And that's actually a part of a benefit for 2019 in Louisville, Richmond, and Tampa. It's a post-acute food service, as well as they screen them for loneliness, and those that screen positive for loneliness get a friendly visitor once per month. So that's something exciting that we've been working on this year. And then something else you'll notice just on here, and I've already said it, but the work that we're doing, we want to share our learnings and develop those insights and proof points to be able to, for others to use them. So we often are doing poster presentations and presentations at different conferences and academic institutions in order to share those learnings. I've already talked about the predictive model. I won't talk about it anymore, but if you can leverage it in anything that you're doing, let's talk. It's really important and is a great way for us to begin to have those conversations. I'm going to skip this slide too, just for time's sake. But really, how are we going to reach this and do this for 2020 and beyond? So these are some of the key components, and I just want to spend a few, and I've already talked about some of them, but just wanted to go through these. So for business integration, I've already talked about that quite a bit, but we're a small team of 20. We can't do this alone. So it's really using the tools, the resources, the things that we know and have developed, and getting you all to also help us on this journey and screening people, having these conversations with members, and the work that you're doing, really focusing in on how these social determinants of health can be barriers for our members achieving their best health. So we're going to continue to do that. Provider integration, so really pursuing test and learns in the physician practices and with our community partners is important. Also continue to grow and scale markets, and I like this, it says assessments of what it means to be bold. But really continued market growth, technology and measurement, I'm almost going to talk a little bit more about that, but really just continue to use and expand Healthy Days and our predictive modeling and our modeling work to be able to scale our work. And then I've already hit home on the policy influence a couple of times, but really developing those insights and proof points in the work that we're doing to push for policy change. There's some exciting things in the policy realm if you don't keep up, to probably really pay attention to for next year. CMS has really lightened their guidance on being able to, in certain situations, provide benefits that include some of the social determinants of health within our Medicare benefits. So if you want to talk more about that, let me know as well. So I'm going to pass it over to Amit to talk a little bit more about our IT and data work. So thank you all.
Hi, can you guys hear me? Yeah. So as Sara walked you guys through the board goal strategy, things that we're doing in the board goal market, I'll briefly touch on the data, analytics, and technology work that's been going on in the board goal space, and I lead that work. So as Sara talked about the predictive model, there's so many things that happens behind the scenes, right? I mean, social determinants is kind of tricky in a way, because there are things that happens at the personal level, things that happens within the community. So we are taking into account all those things as we develop predictive model and we develop new pilots. So how we go about doing it? First approach is high-tech, high-touch approach, which is obviously we invest in building relationship with community stakeholders. What that means is we have 7 board goal communities, and we are expanding to 6 more this year. So we're 30 board goal communities now across the nation, and we recently added Houston as well, which has become a board goal community. So we actually bring in different community stakeholders together, build this relationship as we think about building new pilots. So this creates an ecosystem where we help connect community organization to these providers, help members connect to those resources that within the community. But how do we go about doing it, right? I feel like my voice is going in and out. Is it because I'm holding it? Yeah. I'm not used to it. I'm used to the so how do we go about creating it? It's creating that advanced analytics and interoperability layer that, creating the data ecosystem work that we'll briefly get into. So the board goal data ecosystem that we have been building is bringing in multiple layers of data. And this slide looks funny because it's kind of off. So as we think about building the predictive model for social isolation or food insecurity, There are things that happens at the person and the community level that we talked about. But again, data is tricky because social determinant data is tricky because it's publicly available, and there are multiple sources, there are multiple ways to get the data. So what we have done is to create those APIs to bring in publicly available data sources. For example, when you think of social isolation, we have data coming in from USDA, CDC, Department of Education, and I think there are hundreds of different data feeds that we bring in to know about the person. We also buy data, know about the person's social associations, what the household composition looks like, what the income looks like, whether the person lives close to a library, whether the person has enough public associations within that community. So we bring in all that publicly available data into the bold goal data ecosystem. And this is again not a complete list of data sources. There are about hundreds of data points that we bring in, normalize it, and aggregate into the bold goal ecosystem. But also about the resources that exist within the community. Like, for example, if somebody is food insecure, what are those resources that exist within that community? Are there enough food banks? Is there food oasis or food desert within the community? So we bring in a lot of data through data scraping, web scraping, and we create a resource directory as well. For example, for transportation, if a person has access to public transportation, what does the accident rate looks like within that community? So all that data feeds into it. And you may have read that article about your data determines your life expectancy, right? Even within Louisville, you can see such a drastic difference between the person living on this side of the town and the person living on the other side of the town. There is about 10-year difference in life expectancy where the person lives. So this data is very crucial for us to determine, to develop the predictive model, know about the community, know about what intervention would work within that community. And as we develop new pilots, what are those pilots and where should we be focusing upon, and what are the resources if you have to build something from scratch. So that's why this is a big catalyst as we think about the bold goal strategy. As Sara alluded, we have multiple predictive models. We have social isolation, loneliness model, and we recently launched food insecurity model. So how do we go about? We obviously use those models to segment our membership based on their chronic conditions and other life issues, but also use the power of artificial intelligence like natural language processing. We use sources such as case managers node, social workers node, to look for information which we don't get easily from other sources, right? So social workers may be having conversation with the member, and they may have talked about housing, they may have talked about the person not having enough food. So we use the natural language processing to know more about the person, create some insights, not just a score, but also insights about the person. If person has social isolation issue or food issue, is there any resource that can really help the person? They may have transportation needs, so we use that to create a 360 of the person. So we call it social determinant 360. And using the power of services to integrate that into platform, like Sara mentioned about the CGX. So all these scores and insights are actually sent to the case manager, social workers back and saying, okay, well, this person has this score, which he has scored to high on loneliness. So either screen the person, that we do have resource guides and toolkit which helps the person connect to the right resources. So that's kind of a workflow of segmenting, using the power of artificial intelligence, using services that integrating that into the platform, helping our case managers and clinicians address those needs. And this is kind of a busy slide, but it kind of walks you through the bold goal analytic model. So at the very left side, we have data acquisition, where we talk about getting data from publicly available sources, not just the social determinant, but also the screening that happens. We screen the person for food insecurity, social isolation, and healthy days. So we bring that all into the ecosystem and connecting back to the person's claims. So it's creating the 360 of the person. And then we work with the DGO, Data Governance Office, in creating the right predictive models and making that data available, accessible in right fashion using normalized and using appropriate key. I think you are involved in some of the board work as well, creating those models and making them accessible across the enterprise. So that's like the second stage here. And then using that data to create our dashboards like market health scorecard, which gives information about the claims history, about the community. And then we do have a zoom in tool, which is actually very hyper local, which actually we can type in an address. Say in Louisville, you can type in an address and you can see what all social determinants exist within the community. So it's publicly available. You can go to zoomin.humana.com and you can access this tool. But also we use this for discovery, we use that for research as well as developing new predictive model. We are in the process of developing social risk model, which is kind of similar to the MRA risk score. So if you think about a person and where the person lives, what kind of social determinant exists in that person's life, the person will be given a score, social risk score, not just from the payment standpoint, but also thinking about what resources can help the person, what are those insights that can help address their needs. Then moving on to assessments where we can use the power of this data to create new pilots, intervention which are very specific about the community. So as I mentioned earlier, every community is so different, every city within every block is different. So as we think about developing pilots where what would work, if there's any gap within the community, it helps, this data really helps addressing those gaps. Then, as I mentioned, using the power of machine learning on top of natural language processing, we connect those determinants back to the resources. So if we know that these are those gaps in person's life, in social risk gaps, how do we connect that back to the resources and what are those right intervention touch points where it can be integrated into the workflow of the clinicians. And then obviously pilots, we have business integration where we connect these back to CGX. It goes into Go365 and other clinical systems, as well as we use that in building new test and learn platforms, as well as a pilot that's going on in multiple business areas. So going from data acquisition all the way to creating new assessment and implementation plan, that's where the board goal analytics model, and then bringing in the power of data using artificial intelligence and machine learning and giving some real insights, real-time insights to the clinician. I think that was more helpful rather than just giving them a score. And that's where the artificial intelligence and machine learning is playing a big role in addressing those needs. So it's not just about the community needs, but also knowing at the person as well and then giving them the real insights. So I'm going to pause here for a second, and if you have any questions for Sara and I, we'll take those questions. I know we got about 15, 20 minutes. It's zoomin.humana.com. It's publicly available across. So right now it's about the community, but we're also adding in member there. So eventually you can see if you know how many members, and that will be behind the firewall, how many members live in a food desert, how many members live in an area which has high prevalence of diabetes or any chronic conditions. So you can add multiple layers. So it's a layering tool, so you can add layers and see as we start filtering out and segmenting the membership further. But right now it's publicly available, zoomin.humana.com.
I was just going to add that if you all are not aware as well, we have a populationhealth.humana.com. And that has all of the information about, has lots of information really about the Bold Goal, but all of the resources that we have available for food, loneliness, the things that can be shared are on that website as well. So it's great to check that out as well.
Yeah. So if you run this predictive model, like what's that point of contact where a member is reached by Humana? It's either a care manager or if you run this and you somehow they're targeted, right? Like how do we reach back out to them?
Right.
Yeah, so there's a few different scenarios in how it's being used. So It is in CGX and the score is present, so people that are having those conversations with members can leverage that score before they call them. The predictive model is a predictor, so it is a point in time how someone is predicted based on their claims and consumer data that we have access to. So it's important that once they talk to them, that they screen them actually for loneliness using we recommend the UCLA 3-question scale, and then they would offer them the resources. So that's an example. Our pharmacy team is using ScriptMint to also do that with nurses that are having conversations with members about their pharmacy prescriptions. So yeah, it's in the systems and then being leveraged in those conversations with people that are making those outreaches.
You actually integrated it as part of
Their
another
workflow.
conversation.
Yeah, in their workflow. And you never want to, it really doesn't take a clinician, in my opinion, to ask and screen for loneliness and food and some of these social determinants of health, but you always have to know what to do if someone screens positive, right? You don't want to ask the questions and say, oh, have a great day, you're lonely. So we do have those written type resources and material that can be leveraged to help with those conversations. The pie in the sky is eventually we'll have those solutions that work and can make direct referrals to either community resources and be able to track those and or interventions that we scale, but we're not there yet.
To work on loneliness, is there a correlation between loneliness and people needing hearing assistance devices?
Absolutely.
Humana doesn't pay for a lot of these hearing aids, and there's
Yes.
a barrier right there.
Yes, so that's definitely an opportunity. Sorry. The question was, is there a correlation with loneliness and mobility or hearing impairment? And the answer is yes, there is an overlap. So there is the opportunity. We have not taken it upon us to address that opportunity yet. I think it would be some messaging around being able to target those people and let them know about the things that are available to them. And that could be something that we could focus on. But short answer is yes. We even have someone on our OPMO team in the Office of the Chief Medical Officer. That's where we sit. Just a sidebar story because it's very relevant to this. So we developed the Loneliness Resource Guide, which is a longer booklet that is a resource for people to start to normalize loneliness, understand it, how to recognize it, things that can do to help. And when we pushed it out to people, he read it. And so he said he read it with his mom or, had understood that she was starting to be distanced in family gatherings. And they essentially figured out that she wasn't able to hear. And they got her some hearing aids through the benefit, and they saw a total 360 in how she was communicating with people. So, yes. Short answer, yes.
Sara,
Yeah.
I'm just curious, with that predictive model, how much of the, ingredients or some of the inferences that, come from the model that you surface up for the care manager, for instance? Or is it just a score and then they ask questions and then they kind of whether that prediction was valid and invalid, I guess?
Right, so the question, I'll repeat because I know we're being taped. The question is around the predictive model and how much detail do we share with the care managers or those speaking to members about what's making up that score. And the answer is right now, today, it is just the score. So they will know based on the score if they're lonely or severely lonely or not lonely and would have that conversation. However, I don't want to speak too soon for Amit, but the goal would be eventually that we have that more granular information available with that score as well as solutions that we could offer. Not there yet either, but...
Sure. Do they get a chance to kind of say, oh yeah, that was valid, or no, this person after we've done the UCLA, whatever questions?
So they do record the answers.
Okay.
The question was, do we know if once they screen them, do we get that information back?
Yes. It was a false or invalid prediction or about,
Yes, so they record the answers to each of those questions into the system, and then that information is fed back to refresh the models. I don't think we're doing that yet either, but that's what we want to do. So we are getting the data back, and then we'll be using that data to refresh the models over time. Because as we get more data back on those screenings, we do need to make sure that that's all refreshed.
So the inferences that have been made by the data scientists is based on the claims and communicating that we are in the process of getting the screening back from different systems where we actually screen the person so that will validate the model and kind of make the model more robust. But the one thing that I would like to add is the new technology, and which may be of interest to you guys, is the SHARP platform, which is actually, so right now we know that this person has these needs. We are giving them a manual resource guide. Okay, these are the resources that may help you. But we are in the process of testing a technology which actually sends the referral electronically to the community organization. And the member get a text message and a phone call saying, okay, well, you have this need, food needs, and we have scheduled this appointment for you at this food bank at this time. So in Louisville, we are testing this pilot with a company called Unite Us, which has built this platform and which has bring in a lot of community partners on this platform. So the food bank will get a notification saying this member will be seeing you for his needs at this time. So it's like PCP to specialist referral, but this is Humana sending a referral to the community organization.
On the slide that showed your data components, you have a lot of stuff coming from outside the Humana walls, and I wondered whether you can tell if anyone's lonely or just our members. Can you run this model on anyone?
So the question is, we get a lot of data which is public, right? And you can run this model for any member because this is across the nation. I mean, it's a national resource, it's a public resource.
What about non-members?
Of a non-members, I mean, as long as we know the other demographic and other history of the person. So this model is not just based off of just where the person lives, but it's a combination of claims and other demographic information. So there are about 2,500 data points that goes into this model. There are also publicly and privately purchased data sources that from Maryland and KBM that we buy, and we then goes into building this model as well. But again, you can make some inferences based on where the person lives, but again, it's not going to be a true accurate predictor of, because you're making inference about a person just because where the person lives.
So how many of those 2,500 sources are ours? Like 10% of them, 50% of them?
Good question. I mean, I can send you a list of resources. I mean, the list of data sources. I don't know how many, but I think about 132 data points that we get from this public. And then consumer purchase, Maryland KBM has about a bulk of data, and obviously we have lab and EMR and claims and other data sources, which is Humana data. So
I think I would just add that our predictive modeling is heavily focused on claims information. So I think it'd be difficult to do that, but that's a great question. But I think it'd be really hard for us to do that because it's heavily based on the claims information that we have. But yeah, great question.
So you score these members, are they only creating scores for members in these vulnerable communities, or for all?
it's for all Medicare, right? Yeah. All Medicare population.
It's the key is just it's Medicare right now. So all Medicare members have a score.
What's the underlying technology used to basically compare or integrate your geospatial data, like heat mapping and things like that, into it? Are you using like Alteryx, are you using Esri, are you using like a custom-built solution, or?
It's kind of custom-based, but I think the platform that we bring in is our platform where we are actually bringing it together. But I think it's a JavaScript-based technology for the front-end UI. It was built by a vendor called RS21 based in New Mexico that built the technology for us, and it's based on the different stacks, and then it's a cloud-based system as well.
Any other questions? All right, well, if you think of anything afterwards, feel free to reach out to one of us. Happy to answer any questions or talk more. And thank you very much for having us today. We truly appreciate it.